Thank you for joining today's educational webinar with Cancer Support Community Los Angeles. I'm Abby Espinosa, the Program Coordinator at CSCLA, and I'm honored to welcome you to this week's webinar titled A Caregiver's Guide to the End of Life, A Nurse's Perspective. Before we begin, if this is your first time joining us, Cancer Support Community Los Angeles is a premier nonprofit organization providing vital social and emotional support to families facing cancer, including patients, caregivers, and their loved ones, all at no cost. Our programs include support groups, healthy lifestyle classes, social activities, and educational programs such as this one. If you would like to learn more about our services or watch past webinars, please visit our website at cancersupportla.org. Before I introduce today's speaker, please note that your video and microphone are automatically disabled for this webinar. Please enter questions for the speaker into the Q&A feature at the bottom of the Zoom window. Questions will be answered at the end of the presentation. We may not be able to get to all your questions today, but our presenter will get to as many as possible. Please use the chat feature to share comments and resources with other participants or to ask questions of CSCLA. We ask you to limit chat comments to information relevant to this topic. At the end of today's webinar, we'll be joined for a few minutes by Kristen O'Leary-Jones, Cancer Support Community Los Angeles' Director of Development, who will provide information about the Benjamin Society, a group of dedicated donors that have pledged to leave a gift to CSCLA in their will, trust, life insurance policy, or other method of giving, ensuring CSC services are provided free of charge to future generations. Sarah is an oncology care coordinator with 14 years of experience in inpatient hematology-oncology, inpatient hospice and nursing education. She has published articles on a wide variety of topics, including interdisciplinary collaboration, nursing quality indicators, and geriatric issues. Sarah is passionate about supporting patients through the entire care continuum. It gives me great pleasure to welcome today's speaker, Sarah Lowe.
Okay, so this talk is really centered on the things I wish caregivers knew when entering caregiving, especially at the end of life. Like many of you, I have personal experience with caregiving. My mom was diagnosed with stage 4 uterine leiomyosarcoma when I was in high school, and as she became sicker and sicker, my sister and I became her primary caregivers. She did pass away when I was in college, and it was through caring for her that I realized I wanted to be a nurse. There's sometimes a little bit of an ache in my heart wishing that I had more knowledge at the time, because obviously right after that I went and became a nurse. But I do really believe I was meant to have the amount of knowledge that I did. But either way, I would love to share with you some of the things that I have learned and wish that I had known, that could be helpful for some of you in your own caregiving journey. So, quick definition: a family caregiver. The family caregivers are spouse, family members, friends, or relatives of the sick, disabled, and dependent individuals who are not paid for providing care. The care may last for months or years and cover a wide range of physical, social, emotional, or even financial care. And I love that the title of this article was Family Caregiver, the Forgotten Savior, because caregivers are truly just the backbone of not only our medical system, but our society and our community. And even though it is something that's it's like a very large invisible task force. The family caregiver is a medical term that we use, and it does not have to have anything to do with any sort of legal or blood ties to family. It's just the term that we use for the person who is volunteering their time and efforts for a loved one and caring for them. I went to a conference, and the speaker said something that really deeply resonated with me. The speaker was talking about how we talk about patient-centered care with the patient at the center and all of the multidisciplinary healthcare team members surrounding the patient with all their specialty knowledge, but that we actually need to add one more team member, and that would be the family caregiver, because we essentially send the patient home under the care of an untrained nurse. And it just highlights the level of responsibility that is given to somebody who just walked into it. And we are just saying, okay, here you go. go home and figure it out. And I always tell all of my patients' caregivers when I'm talking to them that you all get honorary nursing degrees. And I do mean it. The kind of specialty knowledge that family caregivers achieve by doing their work is amazing, and they really do deserve honorary nursing degrees. Because there are so many things that I would like to discuss. There are some things that I'm choosing to not discuss today. We did do a series called A Guide to the End of Life, a nurse's perspective. And at that time, I discussed some things that I do think are very important, and I would like ask you guys to just find on the CSCLA YouTube channel. In that original talk, I go through the difference between palliative care and hospice care, their distinct differences. I go through different symptoms that are common at the advanced cancer stage and end of life, and the different treatment options that we have for each of them. I also go through a timeline of the symptoms during the end of life, from the weeks before death, the days before death, the day before death, and hours before death. So this talk is going to go and add the additional things that I wish that caregivers would know. And this is a slide from that original talk about hospice referrals. I'm just going to highlight the definition for a hospice referral is for somebody who has a life expectancy of 6 months or less, but that is just an arbitrary number. To be honest, it can be appropriate for anyone who's considered terminal, and that 6 months can just get renewed continuously. It is something that we encourage to consider early, and we'll talk more about that in the rest of the talk as well. But it is meant to forgo curative treatments because the focus is on quality of life and comfort. And often those curative treatments have a lot of side effects that are going to impede on quality care and comfort. So that's just some things to keep in mind. And the other thing I wanted to emphasize for this talk is that while there are many, many resources that the hospice care can provide, the one thing that it does not provide is 24-hour caregiving. That is something that the family or friends or loved ones do have to provide. There are hospice homes in other places in America, but unfortunately, because of our high property taxes, it's not really an option, a realistic option for us where we are living here. But so knowing those things and how there is a lot that's going to be expected for the family caregivers, what is it that I would like you to know? Well, for your health, just like on the airplane, you have to put your oxygen mask on first. If you don't take care of yourself, you won't be able to take care of anyone else. And one of the really basic things that I want to discuss is how to protect your back, because this is going to be incredibly, incredibly important when you are caring for somebody. Protecting your back, but also protecting your body. As nurses, almost everybody on my unit had injured their back, and that is something I worry about for the caregivers that I speak with as well. And so this is basic. You guys have probably already know some of these things, but I do think that it bears repeating. If you are lifting a heavy load, some things to remember. One, plan your lift and test the load, ask for help, get a firm footing, all important things. This one here I want to highlight, bending your knees. And the reason for that is we want the weight of something heavy to go to your quads, because those are long muscles that can handle a lot of regeneration and growth. And the quads and then the glutes were your butt muscles, and your core. Those three I'm going to repeat over and over again: quad, glutes, and core. That's where you want the pressure to go. So you want to be bending with your knees, not with your back when you are lifting something. And so I love that they included this as well, tighten your stomach muscles. And the reason I really appreciate this is because you need to use your core muscles to protect your back. And those core muscles, there are many different muscles that participate in protecting your core. There's one in particular called the transverse abdominal muscle, which is really, really important in protecting your back, but it's very difficult to trigger on purpose without using your breath because it's actually deeply embedded with your diaphragm. And so one way you can trigger that is to either blow out and tighten your muscles or suck in and pull in your muscles. Either way you do that, you should be able to trigger that transverse abdominis to assist in protecting your back. And while you are doing this and you're lifting with your legs, not your arms or your back, with your legs, then you're going to feel that pressure in your quads and your glutes. So you should be tightening that really hard. You want to, of course, keep the load close. And the last one, keep your back upright. These are very basic things, but they add up, and that wear and tear on your body will add up as well. There are back belts that can be helpful. It's just very important to remember that over-reliance on a back belt can actually weaken your back muscles. So if you are using a back belt, you want to be also doing regular exercises without that back belt. And twisting injuries are some of the worst injuries on the back that can happen. Your muscles and your core muscles aren't able to protect you as fully when you are twisting. And so one's going to be really important is that you move not by twisting the top of your body, but you move by shifting your feet, and then the top of your body follows. So if you are not twisting, then you have much more of that ability to engage your core, to engage your quads, to engage your glutes, and to protect your back. And so when you are lifting somebody up, what you want to do is, as you see in this picture, you're going to be positioned in front of the person. You're going to want their legs to be between your legs because you want the center of gravity to be compact and under control. And you're going to bend with your knees. You see that she's actually bent pretty deeply because once again, she's going to use her quads and her glutes. And then as she lifts the patient and you put your hands under the armpits to support so that you can get as much support as possible. And then she lifts with her quads once again. So that's going to be lifting, so unbending the knees and bringing them up. That pressure is going to go on the quads and the glutes, and you're going to tighten that stomach to engage that core. Once again, quads, glutes, and core. And when you help someone sit down, you're going to see in this picture that she's not twisting the upper part of her body. You're going to use your feet to shift your angle sideways so that your whole body will turn, and then you will use your knees to bring that person back down. Once again, quads, glutes, and core. Assisting somebody in sitting up in bed is much more challenging to do in a safe way, and it is one of the reasons why it's actually very beneficial to have a hospital bed if that's an option for you. And I will discuss more about potential medical equipment later. But what you're going to do is, even though you do have to do some bending over, what you want to do is you want to get the patient in a fetal position. You want them compact so that you can control the center of gravity, and then wide stance and use momentum to swing upwards. You are going to shift the weight from one foot to the other so you can use as much of those quads and glutes as possible while you are, of course, using your core to support your back. When you are assisting somebody walking, when there's a concern for falls, this picture, the person who's acting as a patient has a belt that's usually not available. What you're going to want to do is put your hands inside the armpits. So it is usually our instinct to support someone at the elbow, but that's actually not very stable. You want to go ahead and support them underneath the armpits, and you will see that the gentleman has an opposite leg behind the other person's opposite leg. So he's a little bit tilted and he's got a wide stance. So the idea is that if someone buckles in front of you and you have them supported with your arms underneath their armpits, then what you can do is lean back and have that weight falling onto your quad. You're engaging your quads and your glutes, and you gently guide them to the ground. Because falls are a place where a lot of injuries happen for both loved ones who are sick and also for their caregivers. And so getting them down safely and then figuring out what to do afterwards when you can move everybody safely. Now, so much about protecting the body physically is about how to move your loved one safely. And we need to think about repositioning, because as disease advances, as someone becomes weaker and circulation becomes more poor, the risk of pressure and skin injuries goes up. And so you want to think about someone not just laying, as in these pictures, it can also occur sitting as well, but it being in any position for a long time is going to add pressure on certain areas. And when there is too much pressure on a certain areas and the circulation is poor and skin integrity is not so good, you're going to start to develop injuries. And this is going to be your warning sign. This is a stage 1. You're going to see redness around the area where there's been pressure applied. And what you're going to see if it's a stage 1 is you're going to see redness, but when you press on that redness, what's going to happen is that it's going to push the blood away, and you're going to have this kind of white mark where your finger was, and then the blood is going to return and that redness is going to return. That's a stage 1. If you press on that redness and the redness does not go away, that's a stage 2. It's has more injury. And then things can progress to an actual wound, open wound, and so on and so forth. But that's your warning sign that you really want to be offloading pressure on that site. And so there's all sorts of ways that we can go ahead and do that with a lot of towels, blankets, pillows. You'll see these different options for how to offload pressures on different parts of the body, like putting this towel underneath the sort of knees and thighs to take away the pressure there, using blankets and pillows to what we say is float the heels. That's a very common place. The blanket between the knees also prevents the knees from having that pressure. And then having a pillow on the side is going to move the pressure to one side. And then, of course, what you want to do is to move the pressure to the other side at some point so that you have this regular repositioning and preventing that injury. Okay, let me see if I can get this to work. I'm going to try to play this video about a proper positioning to prevent pressure injuries, and we're going to see if we
Loved one, it's crucial to ensure their comfort and well-being. One essential aspect of care is proper positioning, particularly to protect sensitive areas like the heels and buttocks from developing pressure injuries. Here's a step-by-step guide to help you position your loved one effectively. Gather your supplies. You'll need several pillows, foam wedges or rolled towels to provide support and relieve pressure on vulnerable areas. You may choose to use a draw sheet to assist you. Raise the bed to a comfortable level. Explain to your loved one what you're about to do. Support the buttocks to distribute weight evenly and prevent pressure buildup in this area. Elevate the heels. Use pillows or towels to lift the heels slightly off the bed. This helps reduce pressure on the heels, a common site for pressure injuries. Heels may appear red if they are left resting on the bed. Maintain proper alignment. Ensure that your loved one's body is properly aligned while lying down. Avoid positioning that puts undue pressure on any one area. Reposition regularly. To prevent pressure injuries, it's essential to reposition your loved one every few hours. This helps alleviate pressure on specific areas and promotes circulation. Regularly inspect your loved one's skin for any signs of redness or irritation. If you notice any areas of concern, consult with your healthcare provider. Skin breakdown at the end of life is not always preventable, but by following these steps and providing attentive care, you can help decrease the severity of pressure injuries and ensure your loved one's comfort during their time on hospice. For more information on how to prevent
Okay, so a few things that I wanted to discuss from that video.
Pressure injuries. Review.
Okay, a few things I wanted to discuss from this video. They really demonstrated what it would look like to float the heels and to be repositioning someone. This also really demonstrates the benefit of having a hospital bed at home, because one of the most challenging things in terms of protecting your own body is having that bed lifted to a level where you can use your body safely, being able to lift up and down. It also, lifting of the head of the bed and so on, it can do a lot of that work for you. So example, if a patient needs to sit up or your loved one needs to sit up and they're not able to do that on your own, you can lift the head of the bed as high as it'll go and then help them to turn, and then they'd be sitting at the edge of their bed and you wouldn't have to lift them up. There's talked about something called a draw sheet. That is something that I would highly recommend you utilizing. Basically what that is just a plain sheet that you fold. You can fold twice or 3 times, and then you lay that down across the bed where your loved one's bottom is, basically. And so what that is that lets you use that draw sheet to help control how you are moving the patient. And it it uses that as like the center of gravity. And that is very helpful in terms of protecting your body as well. And so in this video, the way that she repositioned was she went onto one side and she pulled that draw sheet towards her. That if you were going to do that safely, something to keep in mind is that you don't want to just be using your back and your hands to be pulling. You want to have your feet staggered and you want to shift the weight from one foot to the back so that you are using your quads and your glutes as well as you are lifting. And as a side note, that is also how you put a bedpan underneath somebody. You have them turn to the side, you place the bedpan underneath their bottom, and then turn them back onto their back. Often it can be a very uncomfortable experience to use a bedpan, and especially if somebody is having a bowel movement, usually people appreciate having the head of the bed up to kind of help with the positioning. So that draw sheet, I highly recommend. Also, if the person is starting to sink in the bed, you can go to the head of the bed and then pull from the drawstring up. But even though she was doing a lot of pulling, and we're talking about pulling, I also want to remind you that pushing is considered safer than pulling, because if you push, then you're using your body weight, and it's also much easier to use your quads and your glutes as well to help with that forward motion. So one option that the caregiver would have had in this video is to go to the other side of the patient, push underneath the drawstring, and then put that pillow underneath. And another benefit of having a hospital bed in this situation is that they could put up the bottom guardrails so that if she were to push, then she wouldn't have any concern of the patient, their legs falling off the other side or any injuries like that. Something we want to remember: use pillows to offset pressure points, use a draw sheet underneath the patient's waist and bottom. Reposition regularly. Our ideal situation is every 2 hours. That's not always possible. That's our sort of ideal goal. a raised bed to a comfortable height if possible, if you have a bed that allows you to do that. And then, like I was saying, use safe body movements. You want to use your quads, your glutes, and your core. It's incredibly important to protect yourself as much as you are able. Talking a little bit about durable medical equipment, some things that can be very helpful for you at home. We have walkers. This is a front wheel walker. That's probably the most common one in the hospital, but there are other options like this one on the side is called a rollator. And just what I wanted to mention about a walker is that often patients use walkers incorrectly, and that they almost use it as like they're putting their body weight on the walker in front and are sort of walking behind it. The idea of a walker is actually that you move the walker first and then you walk yourself into the safety of the walker. And so it acts like a stability point for when you are walking in. So just want to point that out on how to use a walker safely. If a rollator, if this option is available to you, it is a nice option because it has a seat and can also kind of function as a wheelchair. Because traditionally insurance will only cover one or the other. That is one of the benefits of hospice, is that if your loved one does choose to go on hospice, it just becomes much easier to get equipment and things that you need. But until that point, there can be lots of hoops to jump through when it comes to insurance, and often there's be restrictions on what can be provided. But of course, wheelchairs are also really wonderful. The one picture that I picked in particular is a lightweight wheelchair. If that's an option, I always recommend a lightweight wheelchair because it just makes it much easier for the caregiver to fold and to move. Shower chairs are something that can be used inside the shower because, sometimes standing for long periods of time is going to be challenging. 3-in-1 commode is very common as well. So that's one that you can put next to the bed so that someone doesn't have to walk all the way to the bathroom. And it can also be put in the bathroom too, and put like on top of the toilet. You just remove the bucket, and that way someone doesn't have to sit down as far if they're having trouble getting back up. Bedpans, also very, very helpful. And we discussed a little bit on how we would go ahead and use that, or how we would place that under somebody. Hospital bed, if this is an option for somebody who is less mobile and is not able to get up and not so independent, once again, really, really great options. Having the guardrails to assist, it's even become something that the patient can use to help themselves get up, and being able to adjust the height and level of the bed and also the height of the bed as well. So especially when it becomes much more difficult, it can become more difficult to eat or swallow, then we put that head of the bed all the way up to help protect from any sort of aspiration or fluid going into the lungs or food going into the lungs. An option I like to also mention is an alternating pressure mattress overlay. This is just something that can be an option if somebody is having a lot of skin issues, because what this basically does is that it like fills the air in the mattress, but does it in differing places in the mattress at different times. So it's going to by itself do some of that offloading pressure from side to side. You would still want to physically be repositioning the patient because nothing can 100% be better than that, but it is something that can help. Oxygen can be such an important vital part, also just of comfort. A lot of our patients get dyspnea or shortness of breath at the end of their life. It can become a challenge to get oxygen on regular insurance. They do want to see that the oxygen saturation is dropping below a certain point so that they can deem it medically necessary. So even if somebody has shortness of breath, if it's not matched with their oxygen saturation dropping, then it's usually not something that the insurance will provide. So that is one of those things where like, once again, it can be much easier to get those things when you're in hospice. But, we still get them for our patients when they're not in hospice, just that it can just be a little more challenging. And we do need you to come into the office so we can measure your oxygen saturation. And we need those records that actually show that your oxygen saturation is dropping to get that for you. Oh, and I was just going to mention there are different types, and the picture to the left is actually called a portable oxygen concentrator. This one's a really nice one to have, just because it tends to be more lightweight and smaller, but it does need to be charged and plugged in. And so that is one of the benefits of having the other option, where if electricity goes out or something or another, you have this option here. So, pros and cons for each. And so I want to say, the way I say to all the new grads that I train is that you need to be doing some sort of strength training if possible, because you need to be protecting yourself and protecting your back. So I encourage that if that is something you can do, please do. Please take care of yourself. Go to your doctor's appointments. The basics, so much more easier said than done, but still worth saying. If you can, please eat well, exercise, stay hydrated, and prioritize your sleep if possible. I'd like to just throw in there that something that I was sort of surprised by in becoming a caregiver was the incredibly long wait times that would be at the bedside, and just not having anything to do. And sometimes even like the loneliness of it, even when you're in a very busy place like the hospital. But I want to be there. I want to be there at the bedside, but I'm going to be there for hours. And so what I actually like to encourage is that if there's a hobby that you can start that is portable and is, especially if it can be something, this is just a personal opinion of mine, especially if you can have a hobby that is off of screen time, because sometimes being on screen time for very long periods of time, when there's a lot of anxious, overwhelming things going on, can just make things that much worse for your mental health. So having some options, maybe like a Sudoku book or a puzzle, or I would actually bring painting supplies with me, just something to have to do, tends to be just good overall. Cultivating and lean on your support system. It defy the isolation. Just being a caregiver and taking on so much can sometimes mean that you get very isolated from some of those systems that you were a part of, even if you are still working and doing all these things. So I just want to encourage you that to try not to forget that. And if there are people in your community who want to support you and your loved ones, please accept that. And there is one of the best systems that I've seen personally is when there is one friend who is very organized, and they become the point person, and then the family says all of the needs to that one person, and that one person organizes everybody else, so that it's less overwhelming. And that is a system that does tend to work the best when there is something acute and more short term. In the long term, you can still do this. However, you just do it more of like a schedule, like, oh, Mondays is when this person comes visits, and Tuesdays is when this person comes and brings food, or something to that effect. And also having a support group or other people, and it doesn't have to be formalized, that you can talk to who has experience in caregiving, can be very, very helpful as well. Quickly, I want to talk about code status at the end of life. There are 3 types of codes that we normally see: full code, limited code, which means that the patient wants some things but not other things. And then there's do not attempt to resuscitate, DNAR. And what happens during a code? We're going to have chest compressions. We need to go ahead and get deep enough into the heart that we can get it to beat. So it's very, very physical, and we're going to have to get that heart to beat 100 to 120 times. cardioversion, we're going to try to shock the heart and get the rhythm to return, for the rhythm to be not return, because if it's asystole, we have nothing to shock, but to have a heart rhythm that is safe. We're going to put a tube down their throat so we can have machines to assist with the breathing. We're going to give medications that help the heart to contract and get that heart to start working. These are all really important things, and they're actually very important places for full codes in cancer care. For example, for stem cell transplants, they actually have it mandated that you are full code, that if you're going in to get a stem cell transplant, at least at Cedars-Sinai, because we're not going to give you a stem cell transplant unless we think that we can get you through it. And we are putting you through an intense experience. There are places for full code, but at the end of life and in advanced cancer, we get less diminishing returns. So in this study, we saw that the total population, 77% of patients who went through a code blue survived the code blue. And then we've got some patients of those who died, went to ICU and then died, survived to discharge, and 16% were alive at 1 year. So there were patients who benefited, even if we wish that more people were doing well. But patients who had poor prognosis, they were more likely to die in the ICU or in the hospital. And at 1 year, only 2% of those patients were alive. And that doesn't have anything to say with their actual quality of life from having undergone what they went through. And we do see that there's a lot of aggressive interventions at the end of life. And these are the definitions for what the study was looking at. And we do see a lot of correlation of what caregivers report when it comes to increased physical distress of their loved ones, increased psychological distress of themselves, what they considered a bad quality of death, and lower likelihood of dying in the preferred place. And whereas this is a cool part of quoted from the research, whereas those with long durations of hospice care were linked to less physical distress, a better quality of life, and a greater likelihood of dying in their preferred place. But this is all better understood in hindsight. Like, this is not to judge anybody and their decisions. When you are in the situation, it's much, much, much more challenging to see, what is going on and what are the best decisions. Everyone's making the best decisions that they can. But just to say that maybe if your healthcare providers are trying to let you know that they think that this is going to be adding more harm to your loved one, then there's reasons for that, because we do have research demonstrating that it might not be the best thing. It might add more harm. And that's one of the reasons that we do discuss, like, is it appropriate? Like, do we want someone to undergo this in the event that their heart stopped beating or they stopped breathing? It does not mean we don't provide care. We provide all the care. It's just in that event of that sort of emergent situation. One thing I did want to discuss, because in my original talk that I referred to you, Guide to the End of Life, I talk a lot about looking at things differently, being flexible, and considering how we can alleviate symptoms. We know that if we have an incurable disease, it's going to come with incurable symptoms. And we have to rethink how we are going to be approaching them. But there are some situations where we do get stuck in a true catch-22. And this is one that I wanted to mention because this is one that many people might encounter, which is that if we are increasing doses of opioids for pain control, which it is one of our best medications that we have for pain control for somebody with advanced cancer, it's such a big blessing. And yet that also means that it increases the side effects. And so we do then sometimes have to make that balance between controlling that pain and having the patient be alert and oriented and able to interact with their family. And that becomes a difficult choice and is one that should be made while talking to the doctor. I know, like, my mom, towards the end of her life, she was essentially high on her medication. But the funny thing was that we actually found comfort in it because she had such a difficult time breathing, that she couldn't really smile or laugh. And she was able to do that sort of in her last days. And we actually found that really lovely, even if my mom was saying some very silly things. So, every family makes that decision. I wanted to mention that we have some really fascinating research suggesting, not proving, but suggesting that increasing opioid doses in a stepwise fashion under physician guidance does not hasten death. And the theory behind that research has actually grown significantly, that body of research. And this one, because there was a lot of fear, if we give all these opioids, maybe we're going to be hastening death. But the interesting thing was that the opioids decreased the work of breathing, and that actually meant that sometimes patients lived longer. And then there was another research done recently, and that just suggested that withholding or withdrawing invasive interventions, and those are the ones listed there, what they considered invasive interventions, did not hasten death. At least they didn't see a different statistical significance in the length of life. So just something to think about, because it can be very hard. Sometimes we feel like, are we making the right decisions? And it looks like sometimes we can make somebody comfortable without, decreasing their lifespan. I am not going to go into the specifics of all of the advanced care directives and all of the various things. There's a wonderful talk from CSCLA from Karen Warren, so I invite you to look for that. She also discusses the End of Life Act. And we also have the continued series going on, and our social workers are really going to dive into some of these parts. But the one thing I'm going to say is that one of the documents is a physician orders for life-sustaining treatment called the PULSE. It is pink, and that is the one you want to get if your loved one has strong feelings about what they want at the end of life. This is a straight up doctor's order. It's supposed to be put on the fridge. So if emergency services come, they're trained to look at the fridge to see if they can find this pink paper. It's supposed to be scanned and in whatever institutions you're at. And so then this is just like overrides anything, makes it very clear about what is done. A few more thoughts. It's such an emotional roller coaster, and I just want to say that I really relate. I remember just feeling like just that living with that constant uncertainty, not knowing, is this the time to be really concerned? Like, is this the last conversations I'm going to have? Just that uncertainty and that sort of roller coaster you go on as a caregiver of somebody with advanced disease. It is a lot. And while I don't have any solutions necessarily for that, I just wanted to validate that. And we do expect a lot of anticipatory grief. And it is, it can make caring for yourself and the loved one challenging, but it can also make that time more precious. And just want to say that there are ways in which we can spend this time to make it really meaningful for us. And one example I wanted to give is it can be very challenging because our roles are suddenly changing and caregiver becomes the primary identity in a lot of ways for many of us. And whereas we were a daughter, a son, a sister, a significant other, all of a sudden we're a caregiver. But what I have found is that we find my patients and I and everyone who goes through caregiving, we find ways of honoring those relationships as well. it is what it is. We that caregiver part can't just go away. But for example, there was a woman who her husband had a degenerative disease. What she would do is whenever she would come home from work, she would bathe her husband, and that's an act of caregiving. But it also became the time every day where she would tell him about her day, and they would talk and they would connect, and it was a time where they could connect as spouses. Or for me, when my mom became very ill and then I became the caregiver, honestly, it was such a strange situation to be in. And yet I thought I found it a blessing that I could spend time with her because we had a challenging relationship. And I thought I could have spent my entire life and not had the opportunity to actually enjoy my mom. And being in that role like allowed me to do that. It's also going to be very, very normal when somebody passes to wonder if you and healthcare providers did everything possible. Just understand that that's normal. And it doesn't necessarily mean that you or healthcare providers actually did it, that most likely everyone did everything that they could. And I also wanted to point out that it is very common to have a sense of relief after someone passes away. And it can be very jarring to have that emotion. And yet it is very normal because you have been holding on to so much uncertainty and anticipatory grief for so long that there is a release of all of that tension you've been holding. And it's not an easy season, but it is a season where you can let go of that tension and move forward in the next chapter. So I just thought I would point that out because that is often a very jarring thing for people to experience after their loved ones died. And I'm going to say that hope is actually a really important part at the end of life as well, which might seem strange, but there are lots of sources for hope. They might be spiritual, might be what you're leaving in the world, or how you find purpose. There's so many wonderful things, but there's also a very practical thing that everyone can do, and that is that you and your loved one should always be planning things you are looking forward to. So that means things, and those time frames get smaller as prognosis worsens. So these are what we're looking forward to next year. And then it becomes, this is what we're looking forward to in 6 months. And then it turns into, this is what we look forward to next month. This is what we look forward to next week. This is what we look forward to tomorrow. And these are the things that we look forward to today, whether that is FaceTiming with someone, grandkids, whether it is that we're going to watch a show that you both love, anything that it is, that this is that next thing that we're going to look forward to. It really helps keep that time purposeful and full of hope. And I just wanted to honor you caregivers really quick. This is a snippet from a poem, A Blessing for Caregivers and Care Receivers. And to the caregivers who continue to put another's needs before your own, bless you. We know this isn't what you had imagined for your life either, that sometimes you are so tired or lonely or burnt out, but you serve and support and show up anyway. You are worth having your needs met too, but you often don't, because this is what the day requires. This is what love requires. Bless you all you caregivers and care receivers, you who do the hard work of love and hope making. May you receive the love you so freely give others, and then a little extra, because too much love is never enough. So thank you very much. I will open it up for questions. Okay. Okay. I do have, let's see. I do have a Q&A here, a question here. It says, how can we ensure that social emotional support, just as physical therapists, etc., is immediately prescribed for patients when they receive a terminal diagnosis? Yes. I do wish that hospitals had a more automatic system, but it tends to be very dependent on the doctor to be reaching out, and nurses if they notice as well. But there are also things that you can do as a loved one, a caregiver, to advocate. And so some of the things that I would ask for is referral to social work. Like our social workers at Cedars-Sinai, they provide psychotherapy. Um, and they provide psychotherapy and support. Our supportive care medicine doctors, also known as our palliative care doctors, they are so important. um, and our chaplaincy. And I will say about our chaplaincy is that they are you don't have to consider yourself religious or even spiritual to benefit from speaking with a chaplain, because their purpose is about meaning making, the meaning making that for many people feels to be the foundation of their identity and their worth, and how they make purpose. And so our chaplains speak with everybody, and develop and support that. When a patient is in hospice care and they are no longer followed by an oncologist, who then describes when previously oncologist prescribed medication are no longer helpful / useful / needed? Oh, great question. So usually this is the most simple scenario, but not everything. Usually when somebody transitions to hospice, most of those anti-cancer treatments are going to get stopped. But there are lots of other treatments that the oncologist has probably prescribed that are helpful for the patient. And it's usually going to be a hospice doctor who's the one who makes those calls. They may go ahead and discuss it with the oncologist as well, but because they specialize in comfort, they often are the ones who are better able to make those calls about when something is causing more harm than help, and to make those decisions. And I do see another question here. What do you suggest for those long nights when the caregiver can't sleep and all you can experience is the racing thoughts? Oh, I feel you so much. I know that for myself, I had a tendency of spiraling and ruminating. Um, and I, I, I found that it was interesting because I would get very sucked into ruminating on certain thoughts. In particular, for me, it was about like, how was I going to survive getting the news, like of my mom passing? Like, where was I going to be? How was I going to get there? And all of those things and getting stuck in it. And the funny thing is that our real life experiences are often can't be as terrible as your own ruminations, because your ruminations can't factor in things like your support system, your faith, all the other things around that are there to support you. Um, I would recommend some things when you can't sleep and you're experiencing racing thoughts. That is going to be individual on what works for you. Learning how to say no to participating in ruminations. Counseling support is very helpful. Sometimes for me personally, something to doing very simple as of getting off of screen time would assist in like lowering that kind of a flight or fight response that was inside. Um, and even doing something simple like having a nighttime routine in which you can do something that feels like you are winding down. Um, and that sort of like ceremonial process can help your body get out of that fight or flight. Um, And then sometimes, melatonin or something that can kind of help your body get tired and break free from that stress is also something that can be helpful. But I know it is very individual, so I'm not 100% sure if those are the things that will work for you, but just know that I very much understand and that we'll definitely get through it. I believe we're running out of time, so let me turn it back over to Abby.
Thank you so much, Sarah. And in the interest of time, I'd now like to invite Christina Lee Jones to join us to talk about our CSCLA Benjamin Society program.
Thanks, Abby, and hi, everyone. Thank you, Sarah. I'll be brief, but I just wanted to let everyone know that this webinar was presented thanks to our Benjamin Society. Our Benjamin Society is a group of donors that have pledged to leave donations to CSCLA in their wills. It also includes things like giving through life insurance policies or transferring of stocks, other ways of giving that are planned. And this is a really great way as you're thinking of next stage of life and what kind of legacy you want to leave behind or your family wants to leave to include CSCLA in those plans. It's a great way to manage your assets while you're still alive, while you still have that agency to be able to make those donations. And of course, it allows us to then keep our programming completely free of charge to all cancer patients and their family members here in Los Angeles. So if you have any questions, our email is up here on the slide, development@cancersupportla.org. You can also find it on our website underneath ways of giving. And we're going to have future opportunities as well to learn more about specific ways to give different types of gifts through your wills and other assets. Thank you.
Thank you, Kristen. So we have reached the end of our time together. I want to thank Sarah one last time for her time today and for sharing her expertise with us. We truly appreciate you being here. And I'd also like to thank our attendees for your engagement with us today. Kathy is sharing the slide. So if you would like to learn more about Cancer Support Community Los Angeles, please visit our website at cancersupportla.org. And if you have any questions, please feel free to email us at info@cancersupportla.org. We would also like to invite you to join us for one of our classes. It's our Mindfulness is Medicine class, and it meets on Tuesdays at 3:30. And Kathy will change the slide, but if you scan the QR code, you'll be free to register. And again, if you have any questions, have any trouble registering, please feel free to reach out to us. I want to thank Sarah one last time. We truly enjoyed having you here. And thank you to our attendees as well. We hope to see you all at a next webinar. Thank you.